So the challenge in choosing between these agents and deciding whom to treat is real, and let me share with you some of my experiences and biases, but I want to emphasize that there really isn't a single right answer to these questions. In our practice, first of all, we do recognize that while treatment produces a progression-free survival advantage and an overall survival advantage, it also adds side effects and toxicity, and it is being recommended for patients who are otherwise asymptomatic. These folks don't have metastases from their cancer, they just have a rising PSA. Any quality of life impacts that they're experiencing are typically due to the side effects of the hormonal therapies they're on and not due to their cancer directly. So as we recommend treatments, we have a discussion with patients about the potential benefits and the side effects that they might encounter, and are guided by their preferences in deciding whether or not to treat. We also recognize that there are significant costs to these treatments and discuss that with our patients and make sure that they have appropriate coverage to enable them to take advantage of these therapies. I tend to offer these therapies to the patients who represent the groups that have been studied, so patients with a PSA doubling time of less than 10 months. Patients who have a much longer PSA doubling time have a much better prognosis and may not need treatment right away. In terms of choosing between the three drugs, that's really an impossible question. You know, all three drugs produce a progression-free survival benefit and an overall survival benefit that generally looks similar. We at our center have had a ton of experience with enzalutamide, so we've tended to prescribe that more often. We're trying darolutamide, the new kid on the block, and gaining some experience with that, but I can't honestly say that there is a sound way to pick one over the other. I will also note that we are paying attention to specific pre-existing comorbidities. So there is a little bit of an increase in risk in cardiovascular complications with these agents. So folks who have significant cardiac disease give me a bit of pause, and I may be a little more reluctant to jump in with treatment. Folks who've had a history of falls or fatigue, I may favor darolutamide a little bit. The two agents have not been compared head-to-head, and we don't know for sure that there is an advantage, but in the face of making those choices, one has to take the data that's available to us. And at the moment, there's a suggestion from the Aramis trial that falls, fatigue, and cognitive toxicities may be a bit less common. So in patients at high risk of those, what comes to mind is trying darolutamide.